Good afternoon. Welcome to Grand Rounds. My name is Ivor Douglas. I'm based at Denver Health in Pulmonary Critical Care Medicine. It's a sincere pleasure to welcome our visiting NEF lecturer, Pat Nanasinkham, who's the Chief of the Division at VCU and will be introduced by Mark Moss in a second. As everybody comes in, it's our tradition to just take a minute and reflect on and recognize the important contributions and seminal life of Tom Neff, who was a professor here at the university, was chief of the pulmonary division down at Denver General Hospital as it was then, and the director of respiratory care, which it still is an important position, but in those days was really formative and has had a very substantial long-term impact on the interactions between the pulmonary critical care group and the respiratory therapy group at Denver Health. Dr. Neff did medical school at Northwestern University. He was a frontline medic in an evacuation hospital during the Vietnam War. And from what I understand from those who worked with him and knew him, that was a very impactful experience. When he returned to Colorado after Vietnam, he entered our pulmonary fellowship. His face is one of those on the halls of fame if you go up to the 9th floor of RC2. And was very much recognized and warmly appreciated as an expert physiologist, a clinical educator, and someone truly dedicated to patient care. And to this day, there are those who, the long-termers at Denver Health, that warmly remember Dr. Neff, both for his passion and patient-centeredness, as well as his enduring ability to educate at great length. My colleague Mike Hanley tells a story of getting, quote, neffed on a Saturday afternoon, which means that if you finished rounds early and wanted to go skiing, he pulled you into his office for another 3 hours to discuss some minor fine point of lung mechanics or physiology. Both he and Tom Petty were founders of the long-term oxygen outcome study, the LTOT, which is a seminal contribution in the field, and developed the consensus conferences here with the Denver group. Most sadly, Dr. Neff died at an early age. He had lymphoma. But in his memory, an endowed lectureship was established, and we're absolutely delighted, and I haven't listed every Neff lecturer here because they go back far more than just the last 10 years, but I want to just reiterate that Tom, who was, I am told, a great lecturer in his own right, has been memorialized certainly over the last 10 years by some of the true intellectual giants in the field of pulmonary critical care medicine, lung biology, and lung physiology. Last year we were graced with Sally Wenzel, Naftali Kaminski, and Dean Shepard in the 4 years prior to this. It's now my great pleasure to invite my colleague Mark Moss to the podium to introduce our Neff lecturer for 2019, Pat Nanasinkham.
Thanks, Ivor. I had the privilege of being a fellow here too, and I was neffed several times also, and it was a very valuable learning experience. And I think Dr. Neff's sister might be here. Did she make it? Okay, but she was thinking of coming, which would be really nice. So I get the honor of introducing Pat Nanasinkham. His academic pedigree is pretty impressive. He went to Williams College in Williamstown, Massachusetts, then moved on to Wake Forest for medical school, did his internship residency and chief residency at the University of Michigan. We were fortunate to recruit him here to do his pulmonary fellowship, so we'll take credit for all of his accomplishments for his 6 years that he spent here, 3 to 4 on fellowship, and then he stayed on faculty. He was recruited to go to Ohio State. In 2006, he rose to the ranks in Columbus, starting off as an assistant professor, eventually a full professor with tenure. And as Ivor said 3 years ago or 2.5 years ago, he was recruited to Virginia Commonwealth University in Richmond to be the chief of their pulmonary division. Pat has been NIH funded for many years. He was very smart and got interested in lung cancer. You would think that pulmonologists took care of lung cancer, but we really didn't. It was a new wave of investigators that started to investigate lung cancer from the pulmonary side in addition to the oncology side. And he's served on study sections. He's on the editorial board of the premier pulmonary journal, and has published over 100 articles combining all different types of articles. He's really become one of the nation's leaders in lung cancer, and today he's going to talk about microRNAs on lung cancer. Pat, thanks for joining us.
Okay, can everyone hear me? Mic on? Take this off. First of all, thank you so much for the kind introduction. Can everyone hear me at this point? Yes? Okay. Yes, please. Perfect. Okay. I am really, really honored to be here. I'm humbled. I was saying last night I had an opportunity to have dinner, and I said, I really wish that you all had not shown me the list of individuals who've been here before me. It's a little bit like following LeBron James. So I'm going to do the very best I can here to tell you a story and talk to you a little bit about what we do in the lab. And hopefully over the next 50 minutes, I'll be able to kind of weave through some of the research that we do, some clinical pearls for our house staff. Okay, very, very important. Is Marvin here by any chance? Okay. I was hoping for a pearl of wisdom, but apparently I won't get one. So I'm going to talk about non-coding RNAs. I do not have any disclosures at all at this point. And here's what we're going to talk about. 3 things. Number one, I'm going to talk a little bit about the current challenges and opportunities that exist in lung cancer. And I'm really going to frame it from the perspective of looking at early detection, trying to determine who's really at risk. Because after all, for most of the house staff that are in the room, you probably won't necessarily be faced with a decision regarding therapy for a patient. I think it's important for you to have a general idea about that. But more importantly, you're going to be on the front end. You're going to see many patients who are either active smokers, former smokers, individuals who perhaps have not smoked but have a family member who has smoked, and you're going to be faced with that decision of whether or not you need to look for lung cancer. The second point, and I'm sure many in the room can attest to this, you're going to be faced with spots on the lung, nodules on the lung, and trying to figure out, what do I do with this patient? Do I biopsy? Do I get a PET scan? Do I just do a sort of wait and watch and see what happens? So we're going to talk a little bit about that. Then what I'll do is I'll work into the area of non-coding RNAs. And hopefully by the end of my presentation, you'll have a very good idea of how microRNAs at this point are being applied to clinical decision making, both in the setting of early detection, nodule detection, and also in the area of therapeutics. And then lastly, I also talk about extracellular RNAs. And when I talk about extracellular RNAs, we really talk about free-floating RNAs that are in circulation. And I'll show you some studies in that regard. So always have to start with a case. It's really important. And this is a case that's not too dissimilar from cases you probably see here. 62-year-old male presents to clinic to inquire about his risk for lung cancer and being, quote, screened. He saw something online, said, you know what, maybe I should go ahead and get screened. He states that he's obtained several chest x-rays, which were unremarkable. He's a 60-pack year smoker. He quit about 13 years ago, so he did probably the most important intervention that he could possibly do. Hypertension, diabetes, family history of coronary disease, physical examination, pretty much non-focal. So here's what I want you to think about as we get into this presentation. How would you advise this patient on his suitability for screening? Is he at risk? Yes or no? Is he high risk? Yes or no? And how are you going to help him decide? So let's just go over the statistics. And this is really important because one of the reasons why I got into lung cancer research in the first place, and this goes way back when I had an opportunity to work with Mark Geraci and Rafe Nemanoff and others, was because it was really a disease that had been overlooked for a long time. It was essentially what I call the 800-pound gorilla. You see all the time, you will see a march for breast cancer, you'll see a walk for leukemia, childhood leukemia. You'll see a walk for glioblastoma. You don't see much for lung cancer. It's really, even to this day, considered a condition that is self-inflicted. And as a result, many people see this as strictly a smoking-related disease. It's self-inflicted. There's a tremendous amount of guilt that patients carry. It can be a very lonely disease as well. The other point is that it doesn't receive, until recently, a great deal of NIH funding. When you look at funding for breast cancer and other malignancies, they receive much more funding than lung cancer, which is unfortunate, because if you look at the estimated cancer deaths overall, males, females, roughly about 300,000. But when you break it down and you look in males and females, about a quarter are going to be secondary to lung cancer. Many causes that I won't go into detail because I think the audience knows this. But we start looking at some of the molecular causes. One area that's very important that I will highlight again is the fact that lung cancer is a very heterogeneous disease. There was a time in the not-too-distant past when individuals who had lung cancer had really only one or two options. That was it. You got surgery if you were lucky, chemotherapy, radiation, maybe a combination thereof, and then you just cross your fingers and see what happens. You fast forward now, and now we see somatic mutations that are popping up every single day. We know, for example, in the setting of ALK mutations, which cause about 4% of lung cancers, there's clear targeted therapy. In the setting of EGFR mutations, we now are on third generation TKIs that have shown tremendous success. And now, of course, we have the advent of immunotherapy, which has really changed how we approach many cancers at this point. So what are some of the challenges? And I really just want you to focus your attention on the center of this screen. And that is, how do we define high risk? I try very hard to dissuade people from thinking that lung cancer is strictly a disease of active heavy smokers. It is not. In fact, the majority of patients now who are newly diagnosed with lung cancer, are either former smokers or they never smoked. That's over 50% now. So it's not the 68-year-old gentleman who's a truck driver, smokes 2 packs a day of cigarettes. Sure, very high risk. But those aren't necessarily all the patients that we're seeing right now. We're seeing more of a different phenotype coming in at this point. How do you improve diagnostic modalities that minimize risk from biopsy, for example? How do you address false positivity? What's the best biomarker? That is a loaded question. And there are many people around the country trying to determine what's the best biomarker for lung cancer. What's the best biomarker for early detection? What's the best biomarker for surveillance? What's the best biomarker to determine if someone is responding, truly responding to treatment? I would be remiss if I didn't at least say something about disparities in lung cancer. It's something that's near and dear to my heart. And it's something that while we've closed some of the disparities in lung cancer, we still have a long way to go. How do you improve treatment for late disease, for metastatic disease? Because at the end of the day, most people will die from metastatic disease. That'll be ultimately the cause of their death. And then, of course, the molecular heterogeneity. I'll highlight here for you, and let me use this here. Right in here with KRAS, this is really important. And that is because to this day, KRAS still makes up about 30% of lung cancers that we see. And we do not have targeted therapy at all for KRAS. We still treat with standard chemotherapeutic agents. Occasionally we'll try immunotherapy to see if there's a response, but we have yet to this day identified a drug that can truly be targeted, that can truly target KRAS. So I mentioned that disparities is something that's near and dear to my heart, and hopefully I can impress upon you that we still have a little ways to go. We've made progress, but we still have a little ways to go. So what you're seeing here are cancer statistics for African Americans, and this is something that was published in literally the last 2 months. On the left, what you see among males, African Americans in red, Caucasians in blue, and what you're looking at is the rate per 100,000. Clearly there's been a decline. From 1990 to 2015, we've seen significant decline. When you look on the right, on that axis on the right, what you're looking at is a mortality ratio. And what you can see is the red still exceeds the blue. This is in African American males. So if there's one population that we really, really need to target when it comes to lung cancer, it's African American males. And there are many reasons that we see these disparities that I'll get into in a moment. When you look at 5-year survival, early stage, localized disease, this is the kind of lung cancer where you should have surgery. You see the numbers. Among African Americans, again, in red, 52%, Caucasians, 56%. You look at all stages, it's 16 and 19%. One thing that I'm really struck by is the fact that for all stages, 5-year survival for lung cancer is about 18, 19%. If you look back 10 years, roughly, about 17%, 18%. We're not making a tremendous amount of progress. Maybe a little bit of progress. We still have a long way to go. Why is that? The reason is because to this day, the majority of patients who present with lung cancer present late in the course of their disease. The minority of patients that we see are the ones that come in diagnosed with an early stage lung cancer that can be resected and they can be effectively cured. The other point that I'll make about this and press upon you is the fact that when you look at localized disease, 5-year survival, isn't it striking that the 5-year survival in lung cancer for early stage disease is in the 50s? We know for a fact that's not the case for prostate cancer. We know for a fact that's not the case for breast cancer. What do these folks usually die of? They die of recurrence. They die of metastatic disease. This is why it is so important that we push the field forward in terms of biomarkers to try to truly identify where someone is in the course of their disease. Are they truly early stage? Are they truly cured? Do they have any residual disease? Stage determines survival. I think that's obvious to everyone in the room. And when you look at African Americans and Caucasians again, in terms of the stages at which they present, I think you can get an appreciation for the fact that most people present very, very late in the course of their disease. Only about 16 to 20% present early on. So, quick show of hands. This is meant to be interactive, and I want this to be interactive. Quick show of hands. How many people are very aware of NLST, National Lung Screening Trial? Okay. Mostly the pulmonologists. Okay. Very, very quickly, this is a definitive study. Right? This is a definitive study that was published about 7-8 years ago now, basically demonstrating that a low-dose CT scan actually can reduce lung cancer mortality. A low-dose CT scan among high-risk individuals, which we'll talk about in a moment, can actually reduce lung cancer-associated mortality. At the time of that publication, it said it was about 20%, all-cause mortality reduction about 6.7%. We now know that it's probably a little bit lower than that, but it's still in the mid-teens, maybe high teens at this point. So really a seminal study, landmark study that's changed what we do at this point. Here's important. Not all screening leads to benefit in mortality. And this is an area that's very controversial. Many people are still working on this because there have been other studies. Granted, those studies have not necessarily used as inclusion criteria the same inclusion criteria, but nevertheless, they demonstrate that not all screening actually leads to benefit in mortality. Raises an important point that I'm going to talk about again in a moment, but I want to plant it in your mind at this point, and that is, should all the people, those 55 to 74, now it's 55 to 80, should all those individuals be screened? Yes or no? Very, very important. And I'm going to show you, and I'm going to hopefully make an argument to you that we probably should not be screening all of these individuals. And furthermore, we should probably be looking at individuals outside of these inclusion criteria. So, I'd say probably not. Now, you all know and you heard that I was at Ohio State and I was at Michigan, okay? Now, this is easy risk stratification, right? So, you know who's at risk. It's quite clear. If you can't see it from the back of the room, it's Ohio State 41, Michigan 13. This guy decides he wants to take a picture, right? Right, so you can imagine what's going to happen. And I say it because I wish I could see someone come in and I could see a sea of maize and blue and just see one in scarlet and gray and say, that's the one I'm concerned about. It's not that easy. It's just not that easy in lung cancer. I wish it were that easy. Several prediction models I'm not going to go into great detail for interest of time, but suffice it to say, there's been a tremendous amount of work to try to identify additional risk factors that place someone at high risk for getting lung cancer. And I think you can appreciate, as you look across from left to right, everything from age, of course, it's factored in, smoking history, family history, asbestos exposure, prior cancer. Recall, in the National Lung Screening Trial, it's only two things: age and smoking history. If you're 55 to 74, okay, you meet criteria. If you have a 30-pack year smoking history, you either are actively smoking, or if you quit within the last 15 years, you're okay. I have patients that come to me, but Pat, what about if both of my siblings died early from lung cancer? Well, you don't necessarily meet criteria, at least based on the National Lung Screening Trial. Gosh, what about if I was exposed to asbestos for a good 10, 15 years? Well, based on the National Lung Screening Trial, you don't necessarily meet criteria. So this is a study that I want to highlight for you, and I'm going to get through it relatively quickly and hopefully get some points across to you. If you look among patients in the National Lung Screening Trial and you start to factor in additional variables beyond age, beyond smoking history, and you determine their risk, and you say you have risk X for getting lung cancer in the next 5 years. You have risk of dying from lung cancer in the next 5 to 6 years. What does that look like? If you factor in these additional things, do you really need to screen all of these people when you factor in these additional variables? So here is, based on this analysis, Stephanie Kowalczyk, what she did was she determined basically the 5-year risk of lung cancer death among these individuals, and she put them in quintiles. First quintile, well, your risk is 0.15 to 0.55%. All the way to you have a risk of greater than 2% of dying from lung cancer in the next 5 years. And there are a couple things that I want to point out as you move to the right. I want to point out one thing, and that is false positivity. All right, overall false positivity, about 93.5%. And you can see how the false positivity starts to drop based on the calculated risk. Number of false positives per prevented lung cancer death. When you get all the way to the highest quintile, it's only 65. And then lastly, something that we always like to factor in, and that is the number needed to screen. 161. Look at the other extreme. What if you decide to just screen these individuals who have a really low risk, 0.15 to 0.55? Look how many people you need to screen to essentially save one person. If you were to go to the hospital and say, I would like to establish a lung cancer screening clinic, I say, great. How many people do you need to screen, they would ask. Well, I only need to screen 5,276 people. Okay? Imagine the response you would get. If you go to the same individuals and you say, 161 individuals, I can actually have impact. I can help one person, keep one person from dying from lung cancer. It's a big difference. It's a big difference. Risk determines benefit, and this is just another way to look at it. But for the House staff and even for my pulmonary colleagues who see these patients, remember, the risk is going to determine the benefit. I would argue that we should not necessarily be screening all individuals that we're screening at this time. We have to be a bit smarter about this. In fact, if you look at additional studies, what you find is this. Among those individuals who were screened in the NLST, if you do a sub-analysis, you find people in that group that actually don't benefit. They don't benefit at all from being screened. 55 to 74, 30-pack year smoking, the patient, 55-year-old female who quit smoking 14 years ago. You calculate her risk and you calculate additional factors, you find that she's not going to benefit from that. It's actually those smallest, the top two quintiles that actually make up the majority of the benefit from screening. So I'm saying essentially that we are over-screening. We are not screening the right individuals. These are some of the risk factors that come into play. This is Martin Tamagi's paper. And basically what he shows you is that if you're going to assess someone's true risk, you need to be looking at additional factors. When you compare NLST criteria versus the PLCO, which is Martin Tamagi's study, you start to see differences in positive predictive value, a difference of 3.4 versus 4%. So let's go back to the case. How many people, based on that case, would like to screen that individual? Only 2 people. Nobody wants to screen that individual. Let me remind you, he's 62 years old. He smoked before, a fair amount. He quit 13 years ago. He has some comorbid illness. He wants to be screened. How many people think he should be screened? Okay, now people are starting to come out. All right, yeah. So this is my patient. He came to me. He said, what's my risk? What is my risk right now at this point? I said, well, you have significant risk based on the fact that you are a smoker, based on the fact that your age, you have some risk. And he'd also had a remote history of a melanoma. I said, you have some risk. Okay? So, quick show of hands. How many people would get a chest x-ray? No, right? CT scan. Here's a CT scan. Can everyone see the abnormality? If you can, I'll show it to you. Right here. Okay? 12 millimeters maybe, 11, 12 millimeters in size. Here are your options. PET scan, show of hands. No PET scan. Biopsy, show of hands. A few. Watch and wait. Watch and wait. Okay, fair enough. What if I told you that nodule, his risk is 12%? It's 12% chance that this might actually be a cancer. Would that change what you would do? This is the exact conversation that I had with him. The exact conversation. This is the indeterminate lung nodule, and I'm going to show you how we're using additional biomarkers to help in this particular case. What percentage of patients screened by CT and NLST had a positive scan? Nodule greater than or equal to 4 millimeters. A, 5%. B, 25%. C, 1%. D, 10%. E, 30%. Okay. I think there are a few people who got it. 25%. Okay. Yeah, I see you all high-fiving back there. Absolutely. There's no prize. I'm sorry, but there's no prize. But I'll at least acknowledge you. There's no prize, but I'll acknowledge you, of course. Second question. Of nodules that are detected in the setting of screening, what percentage of those nodules are proven to not be cancer? Does anybody want to shout that out? Yeah, 96.3%. Okay? So we have an issue with false positivity, significant false positivity in lung cancer screening, which obviously impacts issues of patients getting biopsied, unnecessarily biopsied, patients missing days of work just from the anxiety of having a nodule and knowing they're going to need to have something done. It has tremendous impact. To the point now, we've actually shifted what we consider to be a positive screen. Okay? Previously 4 millimeters. Now we consider 6 millimeters. For the house staff, 6 millimeters is what we consider to be positive screen. So if a person has a nodule that's 5 millimeters, 4 millimeters, unless there's some special circumstances, we don't consider that to be a positive screen. And then lastly, I just want to highlight for the residents and even for my pulmonary colleagues, there are tremendous resources online for doing solitary nodule calculation. I do this for every one of my patients. To give you an idea of how we conduct lung cancer screening at my institution, we actually have a freestanding lung cancer screening clinic. Patients come to us, they're referred to us as being high risk. They come to the clinic. We subsequently do shared decision making. They get a CT scan. We do our CT scans in real time. So we review the results in about 15 minutes with the patient. We go over the results. Prior to that, we've done a risk calculation, and then we provide smoking cessation, and then we also enroll them in our biomarker study. So that's been the model that we've used. I'm going to skip that slide. Here's the holy grail, and that is liquid biopsy. There are many groups, including our own, trying to develop liquid biopsies that may inform clinical decision making, and in two particular areas that we focus on. One is screening, early detection of cancer, and then stratification. Those are the two areas that we're focusing on primarily at this point. And I'm going to introduce you to might be a new concept for some of you, and that's the concept of extracellular vesicles, or exosomes, and how those are being used to inform our clinical decision. How many are aware that there are FDA-approved biomarkers for lung cancer, determining risk, and also for nodule detection? How many are aware of that? Okay. How many are now aware that there are? Thank you very much. Okay, very good. All right. So the reality is that there are several. And like everything else, each investigator chooses their particular area. You have the proteomics group, you have the CTC, circulating tumor cell group, you have the circulating DNA group, you have our group, which does the exosome work. But the reality is that none of these have really been able to provide added benefit, or minimally, to the clinical decision. The reality is that we're really good at this. We're better than we'd like to think at determining risk. We're better than we'd like to think in determining whether or not a nodule is malignant. So this is kind of an overview of what we do in our laboratory. We're very, very interested in developing novel biomarkers that can help us with our clinical decisions. Most of our focus as of late has been look in two different spaces. One is in bronchoalveolar lavage, and the second has been to look in circulation. So very quickly, because I did mention I was going to talk about non-coding RNAs, and that's what we're going to kind of get into. Hopefully most people have heard of microRNA, but to just simplify for everybody in the room, these are essentially 22, 24 nucleotide in length. They're non-coding, but we now know that they have tremendous ability to target mRNAs and to actually completely shift pathways. All right? MicroRNAs first identified in the early 90s. And you fast forward now, there have been maybe 8,000, 9,000 papers in the microRNA field. What's amazing is that very few have actually reached clinical application. And I'm going to talk to you a little bit about why. So how do they work? Basically what they do, they target the 3' untranslated region of an mRNA, and they can cause degradation. They can also interfere with protein synthesis as well. And they're really only one of several types of non-coding RNAs. There are many. You're going to hear non-coding RNAs at some point, or you might see it in a manuscript or somewhere else. The thing to understand is that there are multiple different types of non-coding RNAs. MicroRNAs only represent one of many. So as I mentioned, first described in 1993, there have been a multitude of manuscripts looking at microRNA deregulation in cancer. The earliest studies were kind of like this study. Take small cell, take non-small cell, or you take smokers, you take individuals with lung cancer, you do next-gen sequencing, or you do nanostring, or you do some other modality, some other platform, and then you subsequently look to see which microRNAs are dysregulated. Then you go in, you identify one microRNA and determine what it does. That's a fairly standard approach. But the reality is that hasn't been reliable enough, not reproducible enough. In fact, right now there are only 2 microRNAs that are in clinical trial, MIR-122 for hepatitis and MIR-16 for malignant mesothelioma. And that's it at this point, for many reasons. These microRNAs are known to impact many hallmarks of cancer. And I won't go into great detail, but suffice it to say that, and this is drawn from something that, a seminal paper that Bob Weinberg wrote many years ago, where he essentially showed that, or at least he described the hallmarks of cancer. What do cancers really need to do to gain an advantage? Most of these, I think, should be relatively intuitive. Obviously, they invade. Obviously, they can avoid apoptosis. They have changes in their metabolism. uncontrolled angiogenesis, uncontrolled proliferation. The point being is that now investigators have identified microRNAs that can actually target any one of these pathways, and in some cases multiple pathways. I'm going to highlight two for you, miR-124 and miR-29. So, quick show of hands, how many people have heard of extracellular vesicles? Okay, fantastic. So make this a lot easier. So these are, let's see if this works. Well, I was hoping this was going to work, but it's not going to work. Extracellular vesicles, 40 nanometers to a micron in size. And this is really the group, extracellular vesicles. We talk about exosomes, which I'm kind of going to focus on, usually about 40 nanometers to about 100, 150 nanometers, depending on who you talk to, all the way up to microvesicles, apoptotic bodies. These are particles that are released from virtually every cell. These are particles that are very, very dynamic. They change in response to all kinds of stimuli, whether it's changes in temperature, changes in pH, whether or not a person is NPO or they've eaten. There are circadian rhythms to them as well, okay? And what we know only recently is that they actually carry very important information. Whether it's in the form of mRNA, microRNA, proteins, they carry a tremendous amount of information. I would refer you back to the first studies, 1987, Rose Johnstone, that's the first study, demonstrating that there was a process by which extracellular vesicles would be released from reticulocytes. Subsequently, paper 1996 showing that they're released in the setting of lymphoma cells. And now you fast forward now, and you've got probably at least 1,000 manuscripts demonstrating that these extracellular vesicles are released from cells. They're various stimuli that induce them to be released. And now that they really serve as an important conduit for communication between cells, between a tumor and its microenvironment, between two different cells. You know, this is Melissa Piper. And I always get a little bit emotional when I present this, because Melissa is a very dear friend who passed away from colon cancer in her 40s. A brilliant, brilliant, brilliant scientist. And I distinctly recall one day we were sitting this was when I was at Ohio State. We were having coffee. And she said, you know, I just went to ASH, American Society for Hematology. And I saw folks talking about these EVs, these extracellular vesicles. And at the time, we had started to do some microRNA work. And she said, you know, I think there might be microRNAs in there. Now, at the time, it had not been described. It had not been described. There may have been other groups that were working on it. It had not been described at all. So we kind of looked at each other, and she said, you know, we should try this. Let's just look. So we went ahead and got some patients, some individuals to come in, give us their blood, healthy individuals. We started our project. We said, well, let's just look to see if we can find microRNAs. We found these microRNAs. We start writing the paper. We start sending it out. Response. Yeah, that's a ridiculous idea. Then we don't believe it. We don't believe it, okay? This is a lesson in perseverance. Say we don't believe it. We don't think so, okay? We submit a paper, submit again, submit again. While we're on the last revision, paper gets published in Nature Molecular Cell Biology. MicroRNAs are located within extracellular vesicles, so and so. Okay, that is what's affectionately known as getting scooped, right? That's getting scooped. But you know what? Still very positive, because it demonstrated that we were on the right track, and it also spoke to Melissa's just brilliance as a researcher, and we miss her very much. The Society for Extracellular Vesicles has an award in her name at this point, because she had tremendous impact on the field, and I consider myself blessed to have had an opportunity to work with her. So here are some of the challenges, and I kind of talked about these, but I want to really re-emphasize. When you start looking for circulating microRNA in particular, there's one question that always comes up, and that is, where do you look? Where should you look? Should you look in EVs? Should you look outside of extracellular vesicles? Do you look in the whole plasma or serum? Where do you look? There are big issues with lack of reproducibility as well, poor study design. If you look at most of the studies, trying to identify a biomarker in circulation, they will often compare someone with lung cancer to a healthy person, and a healthy non-smoker. That doesn't make any sense because you would never look for a biomarker in a healthy non-smoker. But those are some of the limitations that we see. So this is what we did. We set out to first try to understand, where are these microRNAs located? Where are the mRNAs located? And just to get you oriented to what we did here, we took 17 patients, 10 individuals who had benign nodules, biopsy-proven benign nodules, 7 individuals who had malignant stage 1 lung cancers, again, documented. Conducted next-gen sequencing, and we did next-gen sequencing on 3 compartments. We looked in whole plasma, we looked in extracellular vesicles, and then we looked also in the plasma where we had depleted the extracellular vesicles. And what we found, the take-home message, was that we found not necessarily the number was higher in extracellular vesicles, but we found more of the differentially expressed microRNAs in the extracellular vesicles. So this was our first clue, maybe this is where we should look as we start to build a biomarker. One particular marker that we found, and I'll show you some validation of this marker, was transketolase 1. Had no idea what this was. Very important in the pentose phosphate pathway, and there was one study that had demonstrated that transketolase levels in peripheral blood mononuclear cells actually correlated with PET avidity on a scan. So the individuals who had abnormalities on their chest and underwent PET scan, the brighter it was, suggesting more activity, higher risk for it being malignant, actually had the higher levels of transketolase in circulation. So this is where establishing collaborations with people that you would never establish a collaboration, or at least not think about it, can sometimes be very fruitful. At the time, we were starting to engage with our nano engineers. We had some chemical engineers that we work with. And they had developed some very novel approaches, lipoplex-based approaches, both for detection as well as for therapy. This is Jim Lee, one of my colleagues that I work with, and we actually have some collaborative grants together. And Jim had developed basically a nanoparticle that can actually have a molecular beacon constructed within it. So a molecular beacon is essentially, as you can see here, it essentially functions as a fluorophore quencher. So what happens is you place that molecular beacon, whatever one you want, whatever transcript you want. Let's just say it's microRNA X. You place that within the lipoplex nanoparticle, and using those lipoplex nanoparticles, you can build what we call a nanochip, which I'm going to show you, that can be used to actually capture extracellular vesicles out of circulation, number one, and determine what's inside of those simultaneously. This is what it looks like. What you're seeing here is some bioAFM images of this nanochip before, once you have your lipoplex nanoparticles, and then after you've passed exosomes over them. And what you can see is each of those lipoplex nanoparticles can capture anywhere between 8 to 10 exosomes at the same time. This is the construct. It is essentially a gold-plated chip. It's no different than the size of a standard glass slide. It's gold-coated, and then subsequently pre-coated with these lipoplex nanoparticles. You then can pass either whole blood, which we don't do, plasma, you can do that, but usually we isolate our extracellular vesicles, we bring them up in PBS, and then we pass it over the nanochip. Subsequently, what happens is it's cationic, anionic bonding. So you have, imagine you have the exosome that binds to the lipoplex nanoparticle. The lipoplex nanoparticle has a molecular beacon for your particular transcript that you're interested in. The exosome that's coming out of circulation takes up that molecular beacon. The molecular beacon recognizes that particular transcript. When it recognizes the transcript, it unzips and then it fluoresces. Okay? So you can essentially determine whether or not those exosomes have your particular microRNA or mRNA of interest. The second point is that we use a multi-well or multiplex well. So you can, with a given sample, you can pass a sample through several wells and you can actually look for several different transcripts. And now they're building one that has, I think, about 72, I think. So you could look for 72 markers on the same sample if you wanted to. What you're seeing here is essentially, this is cryo-TEM, just to essentially show you a lung cancer patient exosome, normal donor. This is the lipoplex. And then what you're seeing here is a cryo-TEM of the lipoplex with the actual exosome that's binding to it, really to demonstrate that there is actually true binding that's taken place. Now, obviously people ask, well, do you have an internal standard? And we do have an internal standard. We actually have, we use artificial exosomes that we can put in at any given concentration, and we now know when we place those artificial exosomes, we know based on the concentration that we put in, what signal we should get. And you can see very clear, a very nice stepwise increase in the signal based on how much we put in. So we use that as our internal standard. The other question that comes up is the issue of specificity. So over time, in collaboration with the nano engineers, we've modified these molecular beacons and modified them so that at this point, we can distinguish a single base pair change. Because one question that I guess get asked all the time is, well, how do you know that your molecular beacon might not pick up a different transcript that's off by one single base pair? This hopefully shows you that with this particular construct, here's our wild type, and this is with any single change, whether it's 1, 2, 3 bases, there's no signal at that point. And then there's the issue of repeatability. And what I'm showing you here is essentially repeatability from well to well and also from chip to chip. And hopefully what you can see is we don't see a great deal of difference. We don't see a great deal of difference in each of these. So this is the cohort that we studied. And I'm just going to show you the discovery sets for today. We identified 2 mRNAs in this case that we thought were really good candidates for distinguishing individuals, cancer, no cancer, right? Cancer, high-risk smoker, benign nodule, granuloma, early-stage lung cancer. And the 2 markers are the following: the transketase 1 that I mentioned, and TTF1, which all the pulmonologists in the room know TTF1, okay? Thyroid transcription factor produced really in thyroid and lung, not much else. This is very helpful for us also from the perspective of trying to determine whether or not these are coming from the lung. Are they from the lung in origin? So I'm just going to show you some data from 156 patients, give you an idea they're not that different, that dissimilar from the patient I showed you. Average size, 1.38 centimeters, 1.56 centimeters, 1.4. And this is what it looks like. And I want to make sure that, does this project okay from the back of the room? Yes or no? It does? Okay. So what you're seeing here, 2 things. You're seeing TTF1 right here, okay? And you're seeing TKTL1. And this is fluorescence, using a fluorescent microscope. And hopefully what you can appreciate is that, let's say TKTL1 is one example, TKTL1. No nodule, benign nodule, and these are what we call indeterminate nodules. Indeterminate nodules usually fall in the range of 8 millimeters to 20 millimeters. These are the classic nodules that come up in the clinical setting that you're just not even sure. Like, what should I do? Should I biopsy it? Should I not biopsy it? Not really sure. And of course, you can see with advanced lung cancer, hopefully you can see significant number of TKTL1 enriched exosomes that you're seeing in circulation. This is in circulation, okay? So when we look at it in terms of how effective it is, cancer, no cancer, area under the curve, 0.92, which is pretty good. I think you can see, while it's not perfect, you can see some separation between cancer, no cancer, no nodule, benign nodule versus stage 1 versus advanced stage. You can start to see some differences here. And then when we talk about benign versus malignant nodule, area under the curve of almost 0.8, stage 1 adeno versus smoking control, 0.94. So pretty effective, at least as a starting point. We are now that we've done that, we're now doing obviously validation, external validation at this point. And this is a question that also comes up, and that is, can you track it? So after a person has actually had the nodule removed, can you track these markers? Do they change? Which, if they do, would be additional support that maybe This is related, in fact, biologically related to having that nodule in your chest. I'll show you a couple of examples. Here's one example of a patient. This is their original signal, and this is 1 month, 7 months, 12 months for that signal after the cancer was removed. Another example is at 1 and 12 months. Okay? We have one case here, which is actually very interesting. This is 184. And what you see is that you see a reduction, and then subsequently, you see at about 18 months a rise. We did not know. We were completely blinded to these patients. We'd received these from a surgeon, another institution. We asked about this patient, and we found out that the patient actually had a recurrence right around that time. So while not definitive, at least suggestive that maybe these are markers that we should be following. Back to the case. Ended up, patient got a PET scan. PET scan was negative PET scan. He said, what should I do? I said, well, I said, your risk is 12%. You've got this spot. What do you want to do? He said, well, I don't know. You're the doctor. You tell me. That's what he told me. I said, okay. I said, well, you know what? I have enough concern about it. You have a history of an extrathoracic malignancy. Turned out he'd had some family history of cancer that we didn't know initially. I said, let's just go ahead and get it biopsied. Biopsied, it was a mucinous adenocarcinoma, and he's actually going for his resection at the end of the month. Okay? So, what's the next level? What's the next level of microRNAs? I just mentioned to you that there have been thousands of studies. Most of them have not, at this point, been fruitful. Most of them have not been fruitful. This is a concept known as A to I RNA editing, and I'm not going to go into great detail. But suffice it to say, what you're essentially talking about are these ADAR proteins, right? Adenosine deaminase acting on RNAs. These particular proteins actually can shift an adenine to an inosine, which then gets read as a guanine. Why is that important? Because if you think about it, it can actually change the amino acids in a protein. And in what's germane to our discussion, we now know that they can actually affect microRNAs. I'm going to show you some data on they can actually affect microRNAs. Why is this so important? Why is the concept of A to I RNA editing so important? Because it turns out that in many organs, in normal tissues, A to I editing is actually normal. If you look, there's some papers to show in the lung, there's A to I editing taking place in 80% normal lung. It happens. It's very, very important. This is a study that we essentially published in scientific reports just showing, and hopefully you can appreciate, when we look at normal versus squamous cell, and you can see the clustering. You've got most of the squamous cell clustering here versus normal, and you can see the A to I editing that's taking place. The point being, in lung cancers, the A to I editing is reduced. There's less A to I editing that's taking place among microRNAs. This is based on the TCGA and also independent validation. How does that change things? And hopefully this gives you an idea how it would actually change. You know, microRNAs can target many, many mRNAs, thousands sometimes. What you're seeing here is you're seeing what happens when you have a wild-type microRNA versus the edited microRNA, and what happens to all the genes that they can target. And you can see when something's edited, it completely changes the landscape. It changes what it targets. So extracellular vesicles have been implicated in all aspects and all the hallmarks of cancer at this point. This is a study basically demonstrating that lung cancer-derived exosomes can actually induce EMT. I'll summarize it for you in the interest of time. If you take circulating exosomes out of the circulation of a patient with advanced stage lung cancer, you place them on an epithelial cell, the epithelial cell becomes mesenchymal. It starts to invade, it moves a lot quicker, it changes its appearance. If you target vimentin, which many people know is a mesenchymal marker, you target vimentin, you can actually abrogate that process. So this is an early demonstration that exosomes can actually drive epithelial cells to take on a mesenchymal phenotype. Let me fast forward to this. This is the other approach we're taking, and that is, can you actually target a cancer cell and shut it off in terms of its exosomes that it releases? And this is an approach we've taken where we're using actually nanoparticle-based microRNAs to target Rab proteins to actually interfere with release of exosomes. This is what I talk about, the evolving story and the change in direction that we're going, or the advancements that's starting to take place, to actually target a cancer cell and decrease the amount of exosomes that it even releases. And I want to finish with one thing, and that is targeted mRNA delivery. And this is something that we've been very, very interested in. Many investigators have been working on this, and it's not a trivial pursuit for a couple of reasons. One is, how do you avoid nonspecific targeting? If you have a microRNA, how do you keep it from going to other organs, from normal to normal tissue? How do you do that? How do you maintain a stable microRNA circulation? And then there's the cost that's associated with it. Here's one example. This is again with our colleagues, where we've developed some relatively novel lipoplex nanoparticle formulations to deliver in vivo, where we are essentially, this is an IVIS, and what you're seeing is we're getting primarily uptake within the lung when we deliver these nanoparticles. How does that look? Here's an example using miR-29. And what you're seeing is reduction in the tumor. These are xenograft models, and you see a reduction using the lipoplex nanoparticles. You can see that many of the targets, known targets for this microRNA, whether it be CDK6, which is very potent pro-proliferative gene, DNMT3B, MCL1, which is implicated in apoptosis, all of them are reduced with the lipoplex nanoparticles. And then, of course, you see the images with reduced tumor size. And then lastly, one of my mentees actually is now working on targeting KRAS. And I mentioned to you that KRAS is a big problem. 30% of non-small cell lung cancers are KRAS mutated. We don't have targeted therapy. So what he's done is he's actually developed a very novel artificial microRNA, and this is the important part about it. It actually targets mutant KRAS, but it does not target wild-type KRAS. This is really important. So when you deliver it in vivo, it goes to the tumor, it's going to impact where the mutant KRAS is, but it's not going to impact the wild-type KRAS that may be in many other places. This is an example of what he's done at this point. And this was published just a couple years ago. He published this as a first author in PNAS, which he demonstrated that in vivo it does in fact reduce tumor size. And now what we're doing is developing novel formulations to get better delivery, more specific delivery, longer stability in circulation. So that's kind of a whirlwind of what we're doing, but hopefully you got a general idea of what we do in the laboratory. And hopefully you also got an appreciation for some of the questions that we're still trying to figure out at this point. We reviewed the challenges. We talked about the roles of microRNAs in initiation and progression. I talked to you about extracellular RNAs, and hopefully everyone has at least a general idea of extracellular vesicles and exosomes and their potential as biomarkers and therapeutic targets. And I just touched on targeting KRAS. Obviously, it's a team effort. I could not do this without the individuals that are here. One person that I really want to highlight is Robin Toft. Robin joined our group 1 year ago as a coordinator, and her sole responsibility was to approach patients, high-risk smokers, and individuals with newly diagnosed lung cancer to get blood for our studies. And in 1 year, she recruited 350 patients, which is pretty impressive for a coordinator. And so we could not do this without people like Robin. I have many collaborators, Harvey Pass, who helped us with some of those studies I showed with the pre- and post-surgical levels of our mRNAs. Jim Lee, Yun Wu, Muller-Fabry, as well as Michaela Saviani just joined us as a PhD student. And with that, I'm going to stop, and I really appreciate your time. I'm honored to be here. It's so humbling. Thank you so much for your time. I appreciate it.
We have 1 minute for questions. Anybody have a dying question here? I have one quick one.
Yeah, sure.
The risk prediction models that you showed us, how accurate are they for non-smokers?
For non-smokers?
Yeah.
That is thanks for that question. We don't know. We don't know at this point how good they are for the non. Most of these have been modeled within smokers at this point, so we don't know how great they are. I've tried them at this point, but the question then becomes, it's a difficult road to go down. It's a bit of a rabbit hole because then you say, well, at what percent should I do something, right? If I have a patient who has a risk, if I say your 5-year risk of lung cancer death is 2%, for example, or even 1%, we have a detailed and significant discussion about whether or not we need to start looking in this individual for lung cancer. That's really where I use my cutoff, and the reason is because I know from at least the National Lung Screening Trial, granted now I'm drawing from a smoking trial with patients with smokers, I know that the majority of benefit in terms of lung cancer mortality was really achieved in those quintiles. So if a person falls in some of those highest quintiles, then we do have that discussion. But without a doubt, if they're in the first quintile, which I mentioned to you already, really they essentially don't benefit at all, then we do have that discussion. But for the non-smoker, that is a very personal discussion. It's a personal decision. I've had some patients go one way or the other. It just depends.
Pat, thanks a lot.
Thank you so much.